Dear Pure Urology viewers, good evening one and all. Today actually very important topic related to PCNL. As you all know, in developing countries, the PCNL is done and it is bread and butter surgery for the urologists. It is done in corporate, it is done in own centers, it is done in peripheral practice in nursing homes, it is done in freelancing places. There are certain problems related to PCNL like bleeding, not able to puncture, CM not working. So many problems will be there. So for all these problems, solution is not given in books. Actually, during Corona period, we started Pure Urology only to listen from the seniors how they struggled in the initial period of their career while puncturing, dilatation, when the instruments are not so modernized, when they are not so miniaturized. One such senior in my place at Hyderabad, when I came to Hyderabad, himself he was senior. So he is super senior to all of us, Dr. Ravi Kumar sir. Honestly, why I have given this topic to him is when he was he learnt PCNL from seniors like his own father, the father of urology in AP and Telangana, Dr. Ranganath Rao sir and Dr. Rauf sir. He learnt in proper way, and when he used to go to districts to do the surgery first as part of any urologist. After that, he used to teach the urologist in periphery. After that, he came back to Hyderabad and settled. Many of them come to him and train as part of DNB or part of junior consultants, and they will go back and practice. So 3 phases he has seen. He has gone for his practice to the periphery. He has taught in the periphery and came back. Now his students in Hyderabad are going to periphery. Taking this background, we wanted to listen. I will ask question because I also attained some 20 years of experience, but I have not practiced in periphery. So whatever the problems I faced in the my hospital, I will ask so that it will be useful for the juniors. This is the main point today. So before I hand over the program, I will share his details, and then I will I will hand over the program to Ravi Kumar sir. So how to do PCNL safely in peripheral centers? So MBBS, he did Dr. A.B. Ravi Kumar sir is MBBS MS DNB, Head of Urology, Medicover Hospital, Hyderabad. He is MBBS Siddhartha Medical College, Vijayawada, MS JJM Medical College, Davangere, Karnataka, DNB Gandhi Medical College, Secunderabad. Undergone special training in pediatric urology, Children's Hospital, Philadelphia, USA, and John Duckett and laparoscopic urology training, SLK Klinken, Elbern, Germany, under Dr. Rasfiller, sir. I didn't know this. That's great, sir. Currently, Head of Department of Urology, Medicover Group of Hospitals, Hyderabad. Present Secretary, Hyderabad Urology Society. Previously, Consultant Urologist, Hyderabad Nursing Home, under the guidance of Senior Professor Dr. Ranganath Rao, sir, 1996 to 2016. Professor Ranganath Rao, sir, is the first urologist of AP and Telangana, his own father. Previous positions held are Council Member, AP Genitourinary Surgeons, Honorary Treasurer, AP Genitourinary Surgeons, President SOGAS 22-23, Honorary Treasurer, Hyderabad Urology Society, Joint Secretary, Hyderabad Urology Society, and field of interest is endourology, laparoscopy, and andrology. Achievements and contributions are presented papers in state chapters in South Zone USA conferences, chaired sessions in South Zone USA conference, conducted workshops for postgraduate and junior consultants in endourology laparoscopy, contributed to establishing endourology centers in various towns of Telangana, published a review article in Journal of American Urology Association of Oncological Society of Laparoscopy, a review of 1,000 cases. Professional experience is pediatric urology, one of the first ESWL procedures done in Telugu states, one of the earliest to set up urodynamic lab in Telugu states, performed more than 5,000 PCNL surgeries, both prone and supine. Laparoscopic donor nephrectomy performed more than 300 surgeries. So he has vast private practice experience, I must tell, because I have seen in these 20 years. Taking that, Sir Ravi Kumar sir, you wanted to finish the presentation, then I will ask the questions. or in between I will ask you, over to you, sir, please.
Yeah, thank you. I think you mute on the play.
Yeah, you are on, sir.
You can hear me. Yeah. Yeah, I think we can discuss in the middle because
Yes,
then
sir.
it will be more lively.
No problem, sir.
Yes, you
Yes,
can see
sir.
me.
We are able to see the screen, sir.
Yeah, thank you. So sorry for the initial glitch, and thank you for asking me to share my experiences in the Pure Urology Forum. This is an excellent forum, and congratulations for having more than 10,000 members, if I'm not wrong.
Yes,
That
sir.
correct?
10,500.
Yes, that's a great number. Uh, First, when I joined my father, Dr. Ranganath Rao, Dr. Rauf had just come back from Vienna after his training with Dr. Marburger, and he was doing PCNLs. We were one of the few centers in Hyderabad. So after I joined, he I learned all my PCNLs and ureteroscopies from him. At that time, there was no laparoscopy, either it was open or endourology. So we had a great time at that time, and we used to enjoy the work. And slowly, I started going to the periphery hospitals, uh, especially only where the urologists were there. I was going. I was training them, and of course, I was also learning. So the major problem at that time uh, was reach the peripheral place safe, because most of the time we used to work in the morning. I used to work till 5 o'clock or 6 o'clock, then start off, go to Nizamabad or Karimnagar, finish the cases there, start off again there by 4 o'clock in the morning, go to Warangal and again do cases and come back to Hyderabad in the night. So it would be a hectic 1 day session, and coming back safely home was also difficult, because most of the drivers, they were unable to tolerate my schedule, so they used to run away, and many times uh, I used to end up driving my own vehicle. So I'll create a little definition on what is remote. This is remote places are where surgery has to be performed with many limitations of resources and backups. Surgeries that are done at places where you don't have any reinforcement backup. So if a light source bulb got burnt, then you did not have any backup. If the C-arm didn't work, you did not have any backup. If there was a patient going into sepsis, or patient having any cardiac problems after surgery, there was no backup. Blood was not abundantly available, and it used to be a very tough place to operate in the periphery.
Yes, sir.
Yeah. Yes. Correct. So there are actually three types of setups where I was asked to operate. One was a general practitioner who did not know anything about the urology, and he would pull up all kinds of cases. And I used to land up in extreme problems in those cases. So I stopped operating where the general practitioners were the owners of the hospital. Then there were places where a general surgeon used to pull up cases, which was definitely better than what a GP would do. But ultimately, I chose only hospitals or towns and cities where a urologist was practicing, and both of us would benefit from it. He would learn from me, and I would be very happy that post-operatively he was taking care of all the cases. So it was a win-win situation. Not only would he pull cases, whatever cases which he felt difficult, he would also keep, and we would operate a variety of cases. So it was a win-win situation for both of us, and we used to enjoy uh, the work there. So there can be, as I told you, logistical problems, and there can be surgical problems. Logistic problems. Mhm. Yeah. There used to be logistics. Maybe we'll talk when if there is time in the end. So whatever problems which I faced during the surgery, I would like to tell you. Initially, we used to keep the patient after most of the times it would be under spinal anesthesia. The anesthetist would refuse to give general, so it would be spinal. So in spinal, they would give a spinal on a stretcher, and we used to put the ureteric catheter there and turn the patient prone. At that time, there was no supine PCNL. So during this situation, we used to face a lot of problems when we are placing the ureteric catheter. Like in the males, we used to get the position which you get on a stretcher is very difficult. Prostrate or a high bladder neck would cause J hooking of the ureter, and we would damage the uretrovesical junction. And if you need to do ureteroscopy, we would not be able to do it. And false passages were very common. In females, cystoceles used to create a lot of problems. So in these situations, in the later stages, I would ask the anesthetist to give the spinal on the table only, and we used to do catheterization and RGC on the table. The other thing what I found was that when you blindly push the ureter catheter into the PCS, there were instances where we perforated the PCS, the ureter catheter would be found lying outside, and when we injected the dye, the whole retroperitoneum would become full of contrast, and we would not be able to see anything. We had to pull back the ureter catheter and find the PCS with great difficulty. So the initial first step itself, putting the ureter catheter, you'll have to be very careful in the periphery or outside. If you are not able to pass the cystoscope because of unable to put the position of lithotomy and others, then it would be not an easy case for you to do in the periphery. And there were many instances where the C-arm failed, or the C-arm took a very odd angle like this. On one day, after giving anesthesia, putting the patient prone, the C-arm just got stuck like this. So there was extreme difficulty for me to puncture and finish the case. In another instant, there was one of my colleagues operated on a patient for a ureteric stone, and when he put the patient in position, he did a open surgery, the stone went up. He couldn't find the stone because he was operating in a center where there was no CM. So he closed and brought the case to a place where CM was there, and the next day not the next day, the next week, again we try to do a PCNL. This time the CM didn't work. So two anesthesias failed, and we were successful to operate only on the third instance with lot of pressure from the hospitals, from the patients, from the anesthetists and everybody. So sometimes CMs can make life very difficult. Positioning was uh, sometimes not very accurate because the uh, tables were not good. We did not have good operating tables. Most of the time, we used to operate on fixed wooden tables. I don't know whether you have operated,
No,
but
sir.
we used to operate only on wooden tables because we did not have radiolucent tables. And in many patients, because of improper placement, in one patient, we found that when we turned the patient supine from prone, his neck had got blocked, and his whole face and his eyes were hugely swollen. And we had to counsel the family for a long time till the face became normal. One bad thing that happened with the positioning for me was when we used to do PCNL, we used to, after placing the patient prone, we used to keep the patient's head in a lateral position, not straight down like what we do now. And at the end of the procedure, we found that the patient had developed a massive infarct in one of the hemispheres of his brain due to obstruction of his carotid artery. And this patient went into a coma, and ultimately we lost this patient. This is a very, very rare instance, uh, not found anywhere in the records, but it happened to us because of lateral placement of the head. And sometimes the tables can malfunction, and whatever table that was available was not uh, compatible with a C-arm, and ultimately we had to pull the patient down. And this was the how we managed to do a PCNL in one patient when the table started malfunctioning. So these are all problems which you can get in a periphery. You can even get in a bigger hospital, but you have more tables and you have more C-arms, and so that way you are safer in a bigger hospital or a big city like Hyderabad. So most of the PCNLs are done in spinal anesthesia only. So the kidney keeps moving with respiration. There will be very steep movements, and we usually have to ask the patient to hold his breath before doing any puncture. And sometimes you'll have to first puncture the capsule, make the kidney stable, and then uh, we'll have to do our PCS puncture. And this excessive respiratory movement, in one case in this picture, the PUJ, the ureteric catheter pierced the PUJ and went up because of too much of respiratory movement. And here, once we uh, tried, in this case, there was abnormal ptosis, and not only ptosis, with this movement, it will be sometimes be very difficult to puncture. You are trying to puncture and the kidney will just move away from you whenever the needle is going. In that situation, what we used to do is we used to put folded towel under the belly of the patient to stabilize the kidney so that it would not move. This is one case where there was a very abnormal ptosis, and in the same case, what the technician did was he pushed the contrast very with force, and that ended up rupturing the PCS to make the situation worse. And here you can see my needle seems to be in the PCS, but the guide wire has gone somewhere into the thorax. So see that your technician is good. See that he will inject only small amounts. You tell him not to inject more than 3 cc at a time. And this is another picture with severe extravasation due to high pressure injection by the technician. And in the districts, I would ask my colleagues to still go for a IVP rather than go for a CTKUB, which most of us do in Hyderabad. The main reason being that you can avoid this kind of surprises on the table. You see that in a CTKUB, the radiologist will not be able to predict uh, what kind of a pelvic ileal system is there. So most of our colleagues who are doing individual practice in the districts, they have X-ray machines in their own hospital. So even today, I would still tell them to go for an IVP and not to depend on a simple CTKUB. This is another system which we found after doing an RGP, because in Hyderabad, nobody is now doing IVPs. We end up with systems like this, surprises on the table. This is another two cases where we had a very difficult puncture, and you can notice in the first picture, I was able to puncture only one moiety, whereas the other moiety was having the stone. So I had to dilate this calyx and then try to get hold of the stone in the other moiety, which was very difficult. And in the second case, actually only one calyx was visible. None of the other calyces were visible. So uh, I had to only puncture that one particular calyx, dilate gently and go into the system. And this is, oops, sorry. This is another case where I had a major surprise. You can see that the ureter is lateral and the entire PCS is medial. So I had to, and all the calyces were pointing medially towards the spine. So I had to really think of how to puncture and how to go into this system. Uh, Ultimately, I punctured the middle calyx and I was able to clear. Though, but this was a really challenging and tough case. Luckily, I got away with this. Then the other problems that we see is this kind of radiolucent stones, very difficult to puncture. And once you go inside also, you will not be able to find out where the stone is. And this is one case where there was upper calyceal stone, and to puncture this calyx was very tough because these other calyces were uh, coming in the way, and I had to go very medially, and I had to puncture this stone directly. And in these cases, when you directly puncture the calyx uh, in the medial aspect, you may go through the pleura. You should be ready for doing chest tube placement after the surgery. And here you will also notice that the spleen is absolutely entirely covering the whole kidney. So that makes things worse. So there are multiple other calyceal abnormalities which I have seen, which can cause great difficulty in the doing PCNLs in the periphery. So you have to be careful. Uh, if you can see this, this is one system which can give you a lot of problem. These are what I call long and thin extra-renal calyces. Uh, if you both both the pictures are different patients. If can you appreciate this
Yes,
case?
sir. Yes, yes.
And this,
Long infundibulum with very narrow infundibulum
yes, yes,
with a lot of fat between the infundibulae.
exactly. So if you somehow managed to puncture this. When you dilate, this calyx will tear.
Yeah.
And once it tears, the whole pelvic system will collapse. It will collapse and it will move away. Uh, and you will have extreme difficulty in. One second.
Identifying the tract and going back.
Yes, yes.
Very
So,
difficult. It will
yeah.
slip back and you will see the fat.
Yeah, so you will have to identify where the pelvis is, and it will be like every time you will be searching where the pelvis is. These are not very common, but when you see the CT or when you see the IVP, you should be very careful in selecting your case in these situations. And there are some situations where you try to search for the calyx. We were unable to find this calyx. Then we tried through a RARS scope also. We went to that area and found that it was a totally blocked calyx with multiple stones inside. And this is a very rare system which I have seen only once. I was able to, if you can appreciate, Chandraman, this is a stone.
Yes, sir. Radiolucent, a little bit radiolucent in the background of the contrast.
Yes, yes. But you see the system,
Cross ectopic or what, sir?
it is, yeah, so bizarre. So I was only able to puncture the only one calyx, and gently I was able to clear off the stone. So this is one case which you should not try to do in the periphery. Bilateral stones with a lot of parenchymal destruction is also another. See, when you see, you feel as if it is a easy one, you will be able to operate and clear off. But you see lot of scarring here, the parenchyma has been lost. There is only one small area of the kidney remaining. And here also there is only one small area of the kidney remaining. These are the cases which can go into sepsis and which can cause problems for you. So it is you will have to choose these cases. And here you see that this is a cyst which has got calcified. So unless you are very clear, tell the patient, counsel them that you will not be doing anything with the cyst and we will be only removing the stone. Otherwise, there will be very much of unhappiness and grumbling from the patient side. And these are some X-rays which, if you see this, there was a great controversy between the radiologist and myself whether this was a TCC or a stone. I was very sure that it was a stone. The radiologist was also very sure that it was a tumor. So forcibly he made me to do a ureteroscopy, and I had to show him that it was not a tumor. Then we were allowed to do a PCNL, and these are the matrix stones which can create a hell of a problem for you because they are not visible on CM. You can see even in the CT scan also, they are not very clearly visible. After removing whatever is possible and you're searching, you just put a stent, put a nephrostomy. And in these cases, I would always suggest to keep the nephrostomy open so that whatever small muck is remaining can be brought out. We have used suction and all. In one patient, we had a problem where patient had a single kidney with a lot of this kind of a matrix stone. We removed all the stone, whatever was possible, put an nephrostomy stent, and after 4 days, we removed the nephrostomy. Patient went home, came back with severe obstruction, renal failure, and sepsis. Then we found that more of this material was in the kidney. It blocked the stent, and the whole thing was a we had to again put back the nephrostomy and treat the patient. So sometimes matrix stones can give you help. So beware of matrix stones when you are operating in the periphery. Bifid systems with stones in both the systems can cause you'll have to do multiple punctures and there can be bleeding. So you have to be again be careful with this system. And these are radiolucent stones, and here you don't find any calyx. So many of my juniors keep asking me where to puncture because you don't see a good calyx anywhere to puncture. In these cases, I tell them to puncture at the periphery. So many times when they first start their practice, what happens is getting a puncture itself would be very difficult, and they would be very happy. The needle is here. The needle is here. They will get uh, efflux, and they will start dilating there, and that would be a medial puncture, and they would end up with heavy bleeding. So it was always, I tell my colleagues who are learning to withdraw the needle up to the periphery of the calyx, see whether you are getting an efflux there. Unless you are getting an efflux in the periphery, I ask them not to dilate. And many people, even if they don't get efflux, they try to put a guide wire and they try to search for the PCS. I don't know how they do that, why they do it. But what happens is that ends up with making multiple false passages, and it will not help in finding the pelvic calyceal system. These are some of the cases where you have to be very careful. One kidney totally knocked out because of various reasons. We don't know. There's only this patient only has a single kidney with a stagon. These patients, if you operate in the periphery without support services, you will land up in problems. This is another patient with a large staghorn. So it is better not to operate this kind of cases in the periphery. And this kind of surprise we had once. This CT, we thought the patient was having upper ureteric stones with renal stones. So I went in, pushed the both the stones up into the PCS. It went into the lower calyx, and then we put the patient prone. And when we did a RGP, we were only able to delineate only one part of lower part of the PCS. The upper part was not getting delineated. After great thinking, again we put the patient in supine and did a careful cystoscopy. This was a complete duplex system. So then I had to put two ureteric catheters and did two punctures and was able to clear the system. So a good cystoscopy on the table is again mandatory to see that there are no two ureteric orifices. These are some systems where you can encounter problem. If you see this is a large pelvis, very small calyces. So even if you puncture these calyces, it is very difficult. Sometimes you end up unable to puncture these small calyces, which are in different angles. And then you will be forced to make, what I do in these situations is, I will make a puncture on the periphery of the pelvis. I know I'm doing a pelvic puncture, but I do a puncture on the periphery of the pelvis, dilate gently and remove the stone. Another system which can again give you a lot of problem because of very thin, narrow calyces. I would choose a mini perk in this case and go very gently into the system. And many times you think you have cleared the stones, but again you will find a small stone here, another stone here. So you should be mentally prepared to make 1, 2, or sometimes 3 punctures to clear the system properly. This is one case where I had a very difficult time. Patient came with a CT to me, and he had a PUJ calculus and 2 calyceal calculus. I turned the patient around and I did a RGP. This is what I found.
Oh. It's looking like octopus.
Yeah. So I went back. I took the CT report and I started reading the report completely. I found that the patient had a parapelvic cyst. So what you're seeing in the center, this whole thing is a cyst, and all the calyces are stretched around the parapelvic cyst. So after that, whenever I try to operate, I sit and read the entire CT report, not the impression. So that you'll not make mistakes like that. Yeah, of course. Many times we had cases where in a polycystic kidneys we had to do PCNLs. Uh, Initially we didn't know, and once or twice we punctured, dilated, went into the uh, system. We thought it was system. Then once we entered, we saw that it was only a cyst. So then we started either giving betadine or methylene blue uh, mixed with the contrast, and then we were able to identify that we had entered into the PCS and not into the one of the stones. And horseshoe kidneys, which many a time we do PCNLs. But recently, I have encountered this kind of a horseshoe kidney, which I have not seen before. This is a little bizarre. Actually, this is a horseshoe kidney, but if you see that the calyces here are totally different. There's a stone here. I wanted to do a PCNL and remove the stone, but all the calyces are long, narrow again, and difficult, very difficult to puncture. There is a malrotation in the left kidney. There is a horseshoe with a malrotation. Here you see the right side, you can trace the ureter down like this, which is good. But here the ureter is coming from somewhere else. So in these cases, doing a PCNL would be very difficult and disastrous. So this case, we chose to do a lap pylorolithotomy, and successfully we completed the case. These are other cases which I just wanted to show you that here things would look normal. I have seen that many of my younger colleagues, they go with a lithoclast and they put it on a fast mode and continuously they keep firing, make everything into hundreds of pieces, and only then they will try to retrieve. What happens is, especially when you are firing on a stone like this, in this situation, uh, if you continuously fire with high frequency, you are likely to tear the pelvis. If the pelvis is thin, the stone will go out. And if you see the proximity of the renal vein with the pelvis and the stone, you can very easily injure the uh, great vessels. So you have to be very careful about that. Of course, on the opposite side, incidentally, you find that there is a complete malrotation with another stone on that side. And the other thing what I found was that whenever somebody has a bilateral renal or ureteric stones, the patients and their family keep insisting that it should be operated in the same sitting. I know of many surgeons who operate on bilateral PCNLs, doing bilateral PCNLs in the same sitting. Somehow I'm not comfortable. I do not know about you, Chandraman. You do it?
No, sir. Now I am also not doing. Few years back, 5 years back, when I was doing bilateral RIRS, you said that by the time you reach 50, you will stop it. Exactly, it is happening now. Honestly, I'm telling you, only told. As the age increase, youngsters, because now I feel I don't get any benefit. But if I get any go wrong, patient will not excuse me or anybody will not excuse.
Yeah.
So when you don't get there, when the same procedure has to be repeated, there is nothing great. So if the indication is not there, I stop doing bilateral RIRS. I stop doing bilateral PCNL unless that's a different discussion. So otherwise, routine cases we don't do, sir.
Unless the patient already has bilateral PCNs, then it is a little safe to do bilateral PCNL at the same sitting. Even still, that also I would not suggest. So
Yes,
my
sir. Yes, sir.
philosophy is I want to sleep peacefully in the night. Risk of bleeding, sepsis, renal failure are more. So better do a staged procedure. In
Yes,
other
sir.
cases where you have problems like narrow calyces, multiple small stones, I think we removed some 100 stones in this. You'll have to make two punctures. Again, chances of residue are more. And these are many stagons we operate, but these are cases where you can land in problems. This is a case where there is absolutely no hydronephrosis. The stone is packed in the PCS. The moment you go, you dilate, it will start bleeding because there is no place there. There is no place for the ampullates to sit. It is very difficult. You clear one stone, you feel you will be able to put the ampullates in there. There won't be any more stone there. Neither will you be able to find the passage. The other stone is in another angle. This is another angle. So these are cases which can create potential problems for you. You have to be very careful.
I have also certain questions, sir.
Yes.
Can we take up, sir?
Yes, yes. You mean we can take up a case like this? Yes, you will have
No,
to.
no. We will ask questions. What exactly happens in periphery? I have some questions.
Yes,
Once you finish this, we'll ask because it's 30 minutes, 40 minutes. So how many slides are there, sir?
I'm almost coming to the end.
End. Okay, sir. Okay, sir.
This is another patient. This patient has got a stagon and he has got kyphoscoliosis. So you have to be very careful because the blood vessels here in kyphoscoliosis will be in a very abnormal way, and I have not encountered, but I know of patients who have died when they were being operated for kyphoscoliosis. Of course, other complications are common, which you can read in your textbooks. These are
Yes,
the
sir.
routine complications. Only where I faced the problems, I'll just tell you. One case where there was abnormal movement of the kidney in an old lady. We were with great difficulty. We made a puncture. I did the first dilatation. Once the first dilator went in, there was tremendous bleeding. So we stopped the procedure there, and the patient became bad in the night in the ICU. We shifted next day, did a laparotomy. We found that there was an avulsion of the renal artery from the aorta with the first dilator itself.
Oh my God.
Yes. So that was one major thing. Of course, the other bleeding can be easily controlled by putting a Foley catheter, pulling it, and all that. This is known by everybody. Delayed bleeding. After I've seen all my pseudoaneurysms and AV fistulas, they will go home and they come back with major bleeding. So you have to be careful. Usually prolonged operative time on diabetic patients, staghorn calculus, solitary kidneys. Somehow solitary kidneys tend to bleed. So when you're operating on a single kidney, you have to be very careful. And of course, sepsis is something which we always deal with sepsis. So you will have to be cautious about sepsis. Injury to the hollow viscus, yes, it can happen to anybody. I think it happened to me 5 times. Two were very thin patients. I went into the colon. two patients had previous multiple PCNL, so there also this was expected. One supine PCNL, we were just starting to do the supine PCNLs. I went and punctured the upper calyx, and then also we had a problem. And this is a recent X-ray sent by one of my colleagues on what to do. He had a supine PCNL, and there was he punctured the colon, but successfully he managed by putting a drainage into the. So pleural injury, yes, I had several cases of pleural injury, especially when you are doing an upper calyx puncture. Then most of them can be managed successfully by putting a chest tube. And these are some cases you should be very cautious. A contracted kidney, which will go and snugly sit under the spleen or under the liver with the colon supporting it. There's a colon in the lower pole and the entire kidney is being covered by the spleen. These are cases which can give you potential problems. Spleen and liver also can be injured, but I did not have any experience in this. I think we'll stop here, Chandramohan, and we'll continue with our discussion.
Yes, sir. Yes, sir. Because, yes, sir. Stop share, sir.
Yes.
Because people will expect some questions, how the periphery they will manage. So
Yes.
I had some questions, so I wanted to finish that. Can you stop sharing, sir?
Yes.
Yes, sir. So what I feel is let me focus on the uh, mm, um, let me focus on the peripheral
Right.
practice PCNL. Quickly, sir, quick fire questions, maybe around 30, 40 questions I will be there. Number one, 20
Yes.
years back doing PCNL periphery and now is different.
Yes.
90% of the people, they are doing by themselves.
Yes.
So they know it. Now periphery is not district, it is taluk.
Correct. Correct.
So what you are also practicing now actively, what material we should take in PCNL? For example, when I used to do in Hyderabad, I used to carry pneumatic lithotripter, normal saline bottles,
Yes.
contrast, plug box, and we all have faced this. Now, if you wanted to, hello, Ravi Kumar sir.
Yeah, I'm listening. Hello? Yeah, I'm
Hello.
listening. Hello? You can hear?
What are the basic things? Yes, sir, I can hear, but your face is getting. Yeah,
Cut
yes,
off?
sir. Now it's okay.
Okay.
Now it's okay. So what material how much we have to carry if the local urologist does not have all the material? Do you recommend to carry as much as possible with the equipment?
Yes, we'll have to carry a light source. TV, I hope they will be able to provide. It is there everywhere.
Yes, sir.
So light source you'll have to carry, camera you'll have to carry. Then
Second question, sir.
yes,
I mean, you mean to say that as much as you carry?
I usually take around 20 bottles of normal saline with
So
me.
you should take as many possible with your car.
Yes, especially do not forget the Sidex box and Parasafe.
Yeah.
That is
So
very important because
see,
otherwise he will show you a
see,
formalin.
the senior surgeons will say stop roaming practice, but the freshly passed out has to do roaming practice for their livelihood. So for
Yeah.
all those roaming practitioners, buy a big car with a big dicky so
Yes.
that you can keep. I used to have the Honda City where dicky is very big.
Yes.
It's a long dicky. So paraffin, sorry, that formalin, we used to keep that for all the instruments in case Parasef and Sidex is not there. My second question, sir, is
Yes.
it necessary to get the CT and X-ray of each stone before you start from Hyderabad to the periphery? Is it better to have the case
It
or patient age, patient obesity, patient blood group, patient comorbid illness? better to know in detail and go to the center.
Yes, it is very much important. Most of the time, they will not give you any detail. By
That
the
is the problem.
by the time you go there, there will be lot of problems. You will not be able to see. Sometimes only BTCT will be there. PTINR will not be there. We
Sir, I am telling you one small experience. 10 years back, I have been invited by RIRS. I went, there was nothing. He has given a bucket in which Paracef I have put, and I went inside. There is no stone. Five urologists have come to watch the surgery. When we opened the file, it is my mistake. First, I accept that it was a gallbladder stone and it was read as renal stone. CT not done, and ultimately RGP showed no stone, gallbladder stone was there. Sorry for that. The reason why I'm telling is that when you are doing in periphery, CT, now every district has CT. So better to have the CT film patient characteristics, so that in fact you should charge accordingly, because your stress is also more. If 100 kg patient is there, you may miss the bus. As you have shown nice cases, actually you have shown your surgeries which should be avoided in periphery. Actually, we have to
yes,
take that
yes.
into consideration. My
Those are
third
the
question,
yeah.
my third question, uh, is it necessary at the present stage to have one urologist in the periphery or with you to make the things better, or you can do alone with a nursing home where urologist is not there? What do you think? See, going to a urologist place and helping is easy, sir,
Correct,
because some urologists don't have PCNL practice. They will call from Pune or Hyderabad. It is okay. They will learn over a period of time. They will not call you. That's fine.
correct.
But if you go to a nursing home where urologist is not there and you have to turn, you have to put everything, is it viable a long time? And they don't pay also adequately. Is it viable long time to do that?
Yeah, actually, most of us have a very good technician, interested young boy. We train him very well, and we always take this boy with us, technician, who will look
Yeah.
after all these problems. If you don't take your, if he doesn't
So
come,
the answer is
you
better
are
to
stuck.
have your one technician with you so that he can help you in the theater. This is the fourth question.
Yes,
Now
because
coming to the fifth question,
yep,
I'm moving fast because there are some important questions which I want one answer
okay,
without much this thing. If you go, what type of CM minimum nowadays lag will be there, lag, CM lag. When you
yes,
press the needle, after 10 seconds it will show the needle by the time you have gone inside.
correct, correct, correct.
Present CMs are okay, like Allinger or Siemens are okay. But previous ones, uh, how do you manage? Already patient under spinal anesthesia, he will be moving. So what is the tip and trick where will you tell the patient to stop breathing, or will you assess the CM before you do? What is your take on that?
See, most of the technicians in the periphery, they are used to only showing to the orthopedic surgeons. So they only have one shot idea of giving only one shot and keeping quiet, one shot and keeping quiet. Whereas we need a
Yeah,
continuous cine. So the CM also will have to somehow make some adjustments. There is an averaging in the CM, there is something called averaging. You will have to manage that, increase or decrease the averaging, and see that you at least get a decent uh, cine picture. Otherwise, with this single shots, it is extremely difficult, especially if you have a difficult system. Then on that day, you will have a
it is difficult.
very, very bad day on that day.
Sir, if you pass the needle first time in prone PCNL in periphery,
Yeah.
you get bloody urine. You will get water, but definitely it immature. And
Okay.
you think that it is safe. Honestly, 90% you will get away, or better to try one more puncture, because clear urine, if it comes, okay. But if clear urine doesn't come, it comes with immature, significant immature, not like light pink.
Yes.
Blood mixed, but if you flush, water will come. Will you take it, or you will try to avoid it?
See, many times when you are flushing from below, from the ureteric catheter, it will clear up. The moment you stop, again you start getting clear blood. Then what I
Yes,
do is
sir.
I take very small amount of 1 cc or 2 cc of contrast, slowly inject from the needle and see whether I'm in any artery or in any vein. If that injection what I give is very small amount, if it is going into the PCS, then I'll try to put a guide wire. Sometimes many of, especially PUJ calculus, the whole of the PCS is totally congested, and you continue to get this kind of hematuric urine. So
Yeah.
I
Sir,
inject small amount from above.
you inject contrast small amount and reconfirm and then pass the guide wire.
Yes, if it goes into the artery or it goes into the vein, I will remove the needle and
Remove
go
the
into
needle and
another.
this thing.
Go into
Next question, sir. If you are, what type of puncture you do? You do bullseye or you do triangulation puncture or you do both?
bullseye.
What
I
was,
try,
what
bullseye.
was Dr. Rauf sir was doing and what you learned and what is the change you?
Yes, Ravi sir and myself, we are totally for triangulation only. We never go for bullseye because one thing, your hands will be irradiated. Second,
Okay.
after you enter, your mobility is extremely restricted. You cannot move into all the calyces. A 45-degree nice puncture into the lower calyx is the best puncture for you. Bleeding will be less, and you can access most of the calyces with the lower calyceal puncture.
Okay, sir. If you go into the system and suddenly if you don't see the steen and only blood is seen in the periphery, everything is in periphery, where blood facility is not available, you have
Yes.
not arranged the blood, nicely dilatation done, you go inside, you will see the blood and don't see the stone. How do you proceed, sir?
See, if the patient, sometimes what happens is there will be lot of blood coming out from the side of the nephrostomy. You are inside, you are looking in, everything looks bloody, then you will have to stop the procedure there, put a
Correct, sir.
nephrostomy,
I
come.
wanted a message this honestly from my heart that if significant bleeding that in camera or eye you are not at all seeing anything, if you are periphery on that day better take out the amplage, say next day is better, sir.
Yes.
Especially after significant dilatation, if you have not seen anything, better, especially if it is difficult case tag on, better to be better to go slow and take others' opinion and stop the procedure.
Yes, it is always better to stop the procedure,
Stop the
wait for
procedure.
5 days till everything clears. Then if you are still in doubt, you can do a nephrostogram outside itself, not to
Yeah.
take patient in.
Sir, some patients, I heard that Rauf sir and you people never used to put a Foley's catheter from below and then do the surgery. Is it correct not to put a Foley's in bladder when you are doing PCNL?
I always put a Foley catheter below.
You always put Foley's
I
catheter
always,
because urine output monitoring sometimes may be required.
very important. It,
Very senior surgeon who can finish fast and confident, it's okay. Because
yes,
many of the gynecologists also do laparoscopic procedures without Foley's catheter.
no, that's
We put
very
in all
dangerous.
cases.
Yes, yes. No, even for them, because they operate in the pelvis,
What do
if they don't
you
put
say,
a
sir?
Foley, they'll go and injure the bladder.
Yeah, they unnecessarily bladder will be injured. They think that small ovarian cyst we can come out, but
Yes,
it's Foley's catheter is very simple thing. So, will you recommend to put the Foley's catheter in all cases?
100%. I always recommend.
Yes, sir. Last few questions, around 5 questions.
Yes.
In periphery, when you have cleared 70% of the stone, most of the patients they will not pay if you don't remove all the stone. They will underpay. So surgeon will be under stress to
Yes.
completely clear the stone. In that process, is it safe to go supracostal punctures and do? Lot of people are doing. Juniors are aggressive now. I'm not talking about districts. Next to districts, second puncture supracostal to remove the upper calyceal stone. If first surgery has gone very smoothly, can we attempt, sir?
Yes, we can attempt supracostal puncture. I have done in many cases. Most of the times you will get away, but you have to be cautious. You have to tell the anesthetist. If a patient is in spinal anesthesia, then it is better not to do.
Okay.
If
But
it is in,
lot of surgeons are doing under spinal anesthesia, sir.
yeah,
I
90%.
don't do under spinal, but lot of periphery, they are experts. The
Yes,
moment kidney comes, they puncture, and they are more expert than us because they are used to it and they are adapted. So I really don't know. RIRS also, I feel it's very difficult to do in spinal because complete powder, sometimes it touches the mucosa and causes unnecessary.
yeah, the
uh,
kidney will be full of holes by the time you finish
it
RIRS.
will be full of holes. I
Yes,
also feel, but some people do well. But next question, sir. How
yes,
much duration we should keep in mind when you are doing periphery? Is it the bucket you have to see? Is it the number of saline bottles you have to see? Because anesthetist sometimes will not alarm you. Suddenly he says hypotension has come.
yeah,
Is it the pulse rate we have to watch, or is it the blood color, or is it the duration of anesthesia, surgery, or bulk of the stone? When we should say that stop it? Because in periphery, one more problem. You go every week once or monthly once. If you stop the procedure next month, it will take, or the patient has to come to you. They will
yes,
not like to send to you the patient. So in
correct.
such circumstances, when will you stop? You get tempted to proceed more, 2 hours, 2.5 hours. That can create mortality, in fact, more morbidity.
Yes. No, I keep a time of 1.5 hour. Second thing is I keep watching the efflux from the nephrostomy,
Sir,
from the ampullates. And if it is bloody, then also I'm very cautious. I try to finish early or I will stop and go in the next sitting. And the third is I just keep watching the monitor, seeing the pulse rate.
pulse rate.
Most of the
This
patients.
is
I
what
keep,
I wanted to listen, sir. Pulse rate more than 100, 120 is not at all a good sign, whatever may be. So
yes,
better to stop, especially in young patients. You cannot afford that much amount of pulse rate raise because already compensation is over.
correct, correct.
Sir, in case of sepsis, uh, generally we change. See, sepsis is managed in the periphery, in the corporate, in the everywhere with higher antibiotics. The
Yes.
only thing is when the patient goes into severe hypotension and severe urine output decrease, then hospital will become alert.
Mm-hmm.
If
Correct.
if urine is coming, nobody will like to shift to higher hospital. So we were taught that if you give noradrenaline early, anesthetist. Noradrenaline is a life-saving drug in early sepsis where pulse rate is high, 90/60 is there. We don't know because of the spinal or not. Anesthetist might have gone to other hospital. You
Yes.
also might be in the mood of travel going back. But if you get after 1 hour call that severe hypotension, no urine is coming, it is a bad news. So what is the caution you will give to the surgeon or yourself before leaving PCNL surgery?
Yeah. Ask them to look for all the signs of
Every
sepsis.
15 minutes, if the bleeding is more, every 15 minutes pulse rate, BP, they will inform you.
Yes.
And better to take anesthetist 4 5 hours help in the, better to stay back and pay him more instead of sending him. Because if anesthetist is there, we will be confident. If any emergency happen, they can intubate.
Correct.
What do you say, sir?
Several situations like this, I stayed back.
You
I,
stayed back.
I didn't come back to Hyderabad. I stayed back because these patients, they'll get clot retention. Sometimes there will be significant bleeding. They'll get clot retention and you will have to go back from the middle. There are certain instances where traveling half distances to Hyderabad, I had to turn my car back. So
That is
then,
painful, sir. Very painful.
then after that, I started staying overnight if there was if I suspect any problem. I used to.
Yeah, yeah. The last couple of questions, sir. You see so many students, maybe more than 100 might have gone through your training. Some people will learn fast and some people hold tightly needle and they don't go into this thing. PCNL is a semi-blind procedure.
Yes.
Uh, how to make them, is it that only you have to do and learn, or do you think that simulators, because now everybody in Western countries, they don't have patience. They are
Yes.
spending crores of money on simulators. We have
Yes.
still patients, fortunately. So do you think that simulator practice is better, or take him along with you, try to learn? Because in my hospital, we don't have simulator. They will see continuously. One time we will give needle puncture, one time we give dilatation, one time we give breaking, depending on their seniority. In India, what type of training makes PCNL? How many cases you think necessary for the? Because you might have seen some efficient people, some people learn very fast.
Yes.
With 5 cases, they will do it.
Correct.
Some people will take 20, 30 cases. How do you address them? It's all
Simulators, I have seen many simulators. I don't think anybody will learn anything by doing
simulator.
on the simulators. They, they are not very good. You'll have to learn on the
Patient.
patients. Of course, laparoscopic suturing, don't try to learn on the patient.
Yes, 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 yes.
It will take 8 hours for you to do a
Yeah,
pilot.
yeah.
You should
Laparoscopic
learn how.
surgery, better to do simulator.
Yeah.
So last
PCNL
question.
puncture, you'll
Yeah.
have to learn on the patient. I
Yes.
usually give the needle to my student and I hold from the back. This is the
Yeah.
needle. I give it to him and I also hold from the back.
Yeah, yeah.
I keep moving
In,
and
in Chandigarh, they used to hold everything for us, hand, elbow, everything. But they used to guide, and that is the way we trained. I agree. In institutions, that is the way it is trained, because they will have a lot of students. Last question, sir. When you go to periphery, this is a very, very important question pertaining to you. We have seen you, I have seen you 20 years. Most of the times you don't raise your voice, and you don't look agitated, and you don't maybe a lot of people said that your father is also like that. Maybe it's a genetic. When you travel outside, when the things are not in pace, when you are getting little bit of problems, at least I become very short tempered. That is the reason why I initially stopped going to Karimnagar. I used to go to Karimnagar. I stopped because I was getting nervous.
Hmm.
So, what do you think, the personality versus peripheral practice going? I mean, especially freelancing practice. Some people are gifted like you, that you are calm, and you can talk slowly. Even today, you are talking very slowly and cleanly. What is the advice to keep yourself calm in difficult situations, and get away from the situations? What is the personality that we have to develop?
See, what I've learned is that surgery is a group this thing. It is a team effort.
Like
So
cricket.
yes. So if you agitate the team or if you confuse them, the moment the sisters and all you shout at them, they will freeze. They will,
Performance goes down.
yes, they will stop assisting you. Patient is bleeding, you are trying to do something, you shout at her, you ask her for a mop also, she will not give. She will start shivering.
Yeah, yeah,
I basically, when you are anxious, yes, everybody will like to shout and try to get things fast. But I have seen that in some instances, things will become slow and things will become very haphazard if you are shouting. So it is better to tell them. I also tell them in a firm voice, but not shouting.
shouting. You should not make them confused.
Yes.
You should not. Are you still going to periphery?
No, no, I have stopped about
Uh, you have
6 years.
stopped. Okay. Do you have DNB program with you, sir?
Uh, we had once, we had in the other branch where I was working. In the present branch, I don't have, but we are planning to start.
Planning to start. So, thank you very much, sir, for the insight. And definitely in India, another 50 years, I think, still these type of practices, maybe 100 years, we don't know, because a lot of poor patients will be there. When I want to share a small, Maurya, one surgeon is there. His native place is Kamlesh Maurya is there. He does daily 10 PCNLs. Lot of people do in 10 PCNLs. Even though one PCNL I post video and say that should not be done, this should not be done. Lot of people do hundreds of PCNLs. we wanted actually not many questions have come. They do stags in and out. They do, and it's a very common clinical scenario. See today 450 audience have attended the topic. 450 in the recent past, last 2 years, not more than 250 have attended. So everybody wants to learn this bread and butter surgery much, because they listen also from seniors that we have suffered all this. They will be happy that not only for them. Some people try 5 times, 10 times, 20 times puncture. It will not happen. Same thing will happen to us also.
Correct.
What I do, I change the gloves. I will go out and then coffee. 90% I will succeed. Somehow
Yes.
the brain will get freeze. At that time, you don't attempt in a different place.
Correct. I have seen this in many, my junior colleague will be trying. He'll try for 15 minutes, then he'll call me from the OP, sir, you please come. It will
You
not
get
come.
immediately.
The moment I enter the OT, it would have come already.
It
Says,
would
you
come.
come, sir, that's why it has come.
Yeah, like that they say. Even I go out, sir. I go out to remove
Okay.
my glove sentiment is there. I change the gloves, puncture will happen. Because I will change the position of the entry.
Correct.
So
Correct.
it's all semi-blind. So all the audience, thank you for being with us. It's a huge audience today. So everybody does problem. Everybody has problems. Only thing I feel is try to stop when you cannot, and don't let the patient go into morbidity and mortality. Particularly mortality should not happen in the present era. No patient should die. We have to stop when it is beyond limits, like renal artery tear, dye going into the renal vein and artery, not getting guide wire coiled, and doing more than 3 hours with blood in the buckets. So please don't do that. And over a period of 5 years, I have seen everybody doing well. So thank you, Ravi.